Welcome back to SGMD. Every week we're going to have this topic on the show called Colorful Conversations. We're going to get a chance to talk to scientists, medical innovators, even celebrities, all of whom are right now having an impact on your life. When it comes to healthcare, frankly, I think there's been a lot of noise on this topic and very little understanding. So we want to dig through that a little bit today, really get down to what's happening, how it's going to affect you, and how it's going to affect your wallet. I have two guests here who I think are some of the best in the business. These guys have been writing about this topic for some time and are really willing to sit down and help us dig. Dr. Darshak Sanghavi is the Chief of Pediatric Cardiology at the University of Massachusetts Medical School. He's also the health columnist for Slate Magazine. Jonathan Cohn is here as well. He's Senior Editor at New Republic. He knows the ins and outs of healthcare better than just about anyone. So as things stand now, you support the current bill.
I support the House version over the Senate version. I think both are better than nothing.
Jonathan, same for you?
Absolutely the same.
Jonathan, how might this change the dynamic between the physician and the patient relationship? Most people who are paying attention to this really want to know how it's going to impact them. Will there be an impact on that dynamic?
Well, I mean, I think on a surface level, in terms of you go to the doctor and how is your experience with the physician different, you won't see a lot changing. You will still be able to pick your doctor as much as you could now. If the insurance expansion works, and I believe it would, you'll have an easier time getting to the doctor, you'll have an easier time paying your bills. And I think that's important to remember when we talk about the doctor-patient relationship. For so many people in this country, financial barriers to care change the way they get medical care. You know, you go to the doctor and you get a prescription, and then you don't fill the prescription, right? Or you don't get the follow-up visit because it costs too much. Well, that we won't see that happening as much anymore, so that will change.
With pediatric cardiology, my guess is there's a lot of art to what you do, yes, as well as science. This idea of comparative effectiveness, trying to figure out what works and pay for those things. Yes. That may sound great in principle, especially if you're talking about like economic principles, but when it comes to medicine, things that you may do that don't have definitive proof that they work, are you willing to say, you know what, let's stop doing those things?
I think this is really the key for what actually scares a lot of Americans about healthcare reform. I think that in medicine, as both of us probably know, there's things that we know definitely work. You know, nobody argues about surgery for appendicitis. Mm-hmm. On the other hand, there are things we're not so sure about. You know, certain types of heart procedures for if you have chest pain. We don't really think those really help people out, and there's a tremendous amount of variation in practice. I think what comparative effectiveness research could do in a perfect world is at least make it very clear what we know for sure. Every American, when they go in with a heart attack, should be on a certain type of medication, aspirin and something called a beta blocker. We know that for everybody. On the other hand, if you go in and you have depression, we don't really know what works best. Some people like psychotherapy. Some people may do better with medications. We need to make sure that we give people freedom in those kinds of situations. I don't know for certain what the bill will do for those individuals, and I don't think that's really been clarified.
Jonathan, is there anything in that part of it that scares you at all? This idea that, well, look, yeah, Jonathan, we'd like to help you out, but what the doctor's recommended for you actually doesn't have evidence-based science behind it, so it can't be paid for, it's not going to be paid for. Does that part of it, is that a justified fear?
Well, I think it's always scary when you hear that you might go to the doctor and someone is going to tell you, your doctor recommends this, you can't have it. The two things I always try to remind people, the first is that someone's already doing that for you. If you go to the doctor's office and a physician recommends a surgery and you have private health insurance, your private health insurance company will have the authority to say, no, we're not going to pay for that. Now, the catch is, how is the insurance company making that choice? We don't really know.
I think your point about some of this already happening, whatever term you want to assign to it, rationing or whatever, I think Darshak and I both say we spend a lot of Friday evenings calling insurance companies and lobbying on behalf of our patients. So I think you're absolutely right. It's a fair point. And we'll have much more of our conversation about healthcare, and I think most importantly, why you should care about this if you haven't been paying attention so far. As we continue the discussion, it's worth pointing out a few of the key points when it comes to these healthcare bills. There's a lot in here, so we'll just try and go through this quickly. First of all, insurers must cover sick people or people with pre-existing conditions. Individuals must have coverage as well. We're talking about mandates here, and subsidies for families with income less than $88,000. The critics will say, look, if you start mandating people buy health care insurance, isn't, first of all, that just a kickback to the insurance companies? These people might be healthy. They may not have been buying healthcare insurance. Now you're just forcing them to buy into an industry that some say needs regulating in the first place. Is that a fair criticism? Is that a fair concern?
I don't think it's a fair concern. For one thing, there's a lot of regulation of the insurance industry. To take one obvious example, we are going to limit the amount of money they can spend on administrative waste and profits. We're going to say that you have to spend a certain percentage of your premium dollar on actual patient care. And now they call that the medical loss ratio, which I think is kind of telling that as far as the insurance industry is concerned,
and that's
money.
part of the bill you're talking about.
Yes, yes. But to get to the broader question here, because and people always say, why do we have to require people to get health insurance? Well, it's because if you want to tell insurance companies they have to take anybody, and you think about what would happen if you did that and did nothing else. Because you hear something, why don't we just tell the insurance companies they have to take any customer and leave it at that? Well, what will happen is only sick people will buy health insurance. Because why would you buy health insurance if you're healthy? Just wait till you get sick and then buy it. So now the only people with insurance are very sick. Premiums go through the roof and nobody can afford them. And that's why you get into this bill that will cost $100 billion a year to provide subsidies for people so they make sure that people who are middle class and poor can actually fulfill this mandate and buy the insurance.
The best way to get people who are already sick or have some sort of pre-existing condition coverage is a more comprehensive bill. But it's not going to do anything, Doctor, to cut costs, though, still. I mean, these people, part of the problem is, and correct me if I'm wrong, is they simply cost more money. They're sick, and that's why insurance companies don't want to cover them.
There's no way around that. Taking care of people who are very sick costs a lot of money. And I still am having a lot of trouble understanding how the bill would really affect that. There's a very small percentage of people that consume the vast majority of healthcare resources. Those who are very sick, people who have cancer, those who have heart attacks. And I think that also when you start talking about bending the cost curve, people hear rationing, or they hear what you're interested in is not giving me the best health care, it's trying to make it cheaper. And I think that the fact is that the best health care is not always the cheapest. The best health care sometimes is fabulously expensive. And I think that we have to grapple with that.
Could we potentially be reducing the quality of health care in this country with a bill like this?
I think that this is also something we need to realize, is that many, many people who have private health insurance currently are actually very happy with their coverage. If you walk into a hospital and you've got good insurance, the type of care you get is truly the best in the world. And it's hard to imagine how we could leave that alone and then somehow bring everybody else up to that also and do it for less money. I just don't see how that happens.
I would say, I'll try to make the case for that because I actually think this is possible. There is so much low-hanging fruit, so much obvious waste you can cut out that with some very simple steps you can at least get some money out of the system. Simply by looking at things like anybody who's run a physician's office or been in a hospital billing operation knows the amount of administrative waste we have.
When you talk about this with your friends or, people who aren't as into it maybe as you are, what is the argument that you make? Are you making a moral argument? Are you making a economic argument? Are you making a, this is just the right thing to do argument? How do you sort of tout this to your friends?
The case I like to make is the personal case. We're getting to the point where you say, well, gee, even somebody making $50,000, $60,000, $70,000, $80,000 a year, and they have private insurance, and they get cancer, and suddenly they discover, their policy doesn't cover a lot of the outpatient care they need, or the copays are very high. And now they're struggling. And these are middle-class people. These are people who went to college, who had good jobs, who never thought they'd be in that situation. And my argument to everybody is, don't think it can't be you. Because I've met these people. No one ever thinks it can be them until it happens to them.
All right. Dr. Sean, Jonathan, thanks so much. I hope this is a conversation that we can continue to have and cut through some of the noise that we hear so much of. Thanks a lot. And you've just heard this broken down, I think, in plain English, clearly by two people who understand this bill and seem to support it for the most part. Next week, we're going to take a little bit of a turn and hear some differing points of view on this as well, and also specifically what it might mean for your care and your wallet.